Second try. Okay, so welcome everybody to this week's session on gallbladder mucocoele and how to go from gallbladder to mucocoele. It's a very interesting topic. So we'll talk initially a little bit more about obviously what is the gallbladder, what is a mucocoele, and how does it form? How do we diagnose? How do they present, and how do we diagnose this and diagnose the criteria that we should worry about? What are the warning signs? And then we talk about treatment options and what influence survival. Bit of a takeaway, really. Although I'm a medic, this is a disease that very often, if we can, we will send to the surgeons. So if we quickly look through the anatomy, now we see the liver cells, the hepatocytes make bile, which through microscopic bile caniculae go to the hepatic ducts, and then the bile flows into the gallbladder, which is there to contain the bile and keep a reservoir for when it's needed, and it also concentrates the bile. Now, when we eat a meal with some fatty content in it, both through cholecystokinin and other mediators, the gallbladder will contract if there's normal motility, and that bile will get pushed out through the common bile duct and go into the duodenum through the cystic bile duct. So if that all works well, then obviously those bile salts are mainly there to help to digest fats. Now, what that means as well is that those bile salts and that bile is a very toxic substance, because obviously a lot of our tissues can be digested if they would come in direct contact with the bile. So the gallbladder is lined by a layer of epithelium, and that epithelium produces mucus to kind of act as a barrier and bicarb in there to stop those bile salts getting in touch with the tissue and therefore start digesting it. So normally this layer of mucus is quite thin. So on histology, this is the blue layer that you can see, but it's quite a thin layer if you compare it with how small these cells are. Now, what happens in a gallbladder mucocoele is that, well, let's first talk through. So I think gallbladder mucocoeles have only started to be reported over the last, give or take, 30 years. So 1995 was the first report, but this is now a problem that we recognize quite regularly in our clinic. And what people found, what was abnormal in the first place, is that there was an abnormal amount of this black, thick, sticky mucus in these gallbladders. Some of these dogs had infarction of the arterial supply to the gallbladder and necrosis of part of the wall potentially. They could become secondary infected. You could get, if part of the mucus comes off, it can start obstructing the common bile duct and get bile duct obstruction, or you could get a rupture of the gallbladder wall. And surgery is still and has always been the mainstay of treatment, but a lot of these patients get picked up by medicine clinicians. So what else do we know? And there's some very big retrospective studies these days that show us through who do we see with this problem. So this is very much a problem that we see in small breeds and pure breed dogs. So 90% of the dogs are pure breed dogs, and there's certain breeds that are predisposed for different reasons, really. So Shetland sheepdogs, Border Terriers, Cocker Spaniels, Pomeranians, they're definitely the mainstay. But most of these dogs are smaller breed dogs. It's very rare in the larger breed dogs. And only 10% of the dogs that have been reported have been crossbreed dogs. So again, pretty uncommon. Has been reported in a certain number of cats, but very, very rare. Now, although we think there is some genetic predisposition, what is slightly unusual for a genetic disease is only to come and present at an older age. So the average age of these patients is 9 to 10 years old. Both sexes are seen, and neutering doesn't seem to make a difference on the patients. But what we do know is that a lot of these dogs have concurrent hormonal or endocrine metabolic disorders to do either with the fat metabolism, but there is a large proportion of these dogs that are hypothyroid or cushingoid as well. So what happens in the gallbladder? So the bile, often in these patients, we know that Gallbladder doesn't contract normally for certain reasons, and therefore the bile stays in that gallbladder for longer than it normally should. It normally should get expressed ever so often. But what happens is because of that, the epithelium seems to start producing more and more mucus. And that mucus, as we said, in a normal fashion is there to protect that layer. But what happens now is it because producing slightly different mucus, which is more sticky, the layers are getting thicker and thicker and become more accumulated. So this mucus as well, when you open these gallbladders after you remove them in these dogs, this very much sticks to the wall. If you turn these upside down, there's very little that will fall out of it. You almost have to peel it away from the wall. Now, what happens as well as these dogs, obviously further on, you don't have a normal gallbladder motility and emptying anymore. And we know that that blood supply often gets infarcted and can cause necrosis. So who presents or how do these dogs present? Now, they can present both in an acute way or in a chronic way. People. But the majority of our patients will present in an acute way. Now, presenting signs are very unspecific. So if you look through the list, what's been shown in those different papers, and you look at the top criteria animals present with, we're talking vomiting, anorexia, lethargy, further down the line, diarrhea. But about 1 in 5 of these dogs with a mucocele will not have any clinical symptoms at that stage. So they are incidentally found patients. Now, painful abdomen in some of these patients as well. So obviously what you can see is these patients very much present with gastrointestinal signs and very unspecific, as a lot of our other patients will present as well. Now, if we look at the bloods, again, obviously these patients, definitely the unwell ones, there will be a neutrophilia there, which can be because of pain, stress related, there is inflammation. Some of them might have anemia, often an anemia of chronic disease. And a lot of them, or the majority, will have increased liver enzymes and high bilirubin. But if you look at the percentage, and the variation is what we see in the different studies, we know not all of them have a high bilirubin and not all of them have raised liver enzymes, okay, or raised cholesterol, but a majority do. But if you look at these patterns and say you don't do anything further, these dogs present with signs of GI illness, and the blood's very much fit with that. And that could be considered, the liver values could be very mild elevated, which we see with a lot of the GI problems. And therefore, unless you go to imaging, these dogs won't necessarily be picked up. Okay. So what do we find on imaging if we do take these patients imaging? They are quite patterns that we can discuss. And what we're doing these days is pattern recognition, and we have made 5 stages of ultrasonography changes that we can see and that things can progress through. Okay. Now, what you have to remember on these pictures is that the mucus looks anechoic or black. The bile, definitely if there is a bit more sludge in there and because there's stasis, is often hyperechoic. So in the first stage, what you see there, and I mean, I've made them slightly bigger. So you get this sludgy bile and you get this thicker line of mucus surrounding the gallbladder. Now, as it gets thicker, as you said, it builds up gradually. You get these little blobs of mucus that are coming in, and then you get more and more. These blobs are moving in towards the center and almost pushing that brighter bile into a smaller area, okay? Which you get a stellate pattern that then gradually progresses through to more typical kiwi fruit, where the layers of bile are very thin in between these blobs of mucus. So it's definitely a disease of pattern recognition that relates to that contrast between the darker mucus and the brighter bile getting. Now, the second feature that is essential before you can diagnose definitely the earliest stages of your gallbladder mucocele is this just sludge or is there some mucus there? What you see is when you do the ultrasound and say after 10 minutes, you go back to that ultrasound or to that, check the ultrasonographic appearance of that gallbladder. If it is sludge, it tends to settle down. and you will be getting a line between a denser sludge and a more liquid bile at the top. So to have a mucocele, it has to be a feature that if you change the position of the dog, that the appearance of this gallbladder does not change. Okay, that is an essential criteria. Now, what we know as well is that these dogs necessarily, I mean, when we said not everybody has clinical signs and there's varying degrees of clinical signs, is that the clinical signs are not necessarily related to the stage of disease on ultrasound. So although they become more common, the clinical signs, and the proportion of dogs with clinical signs is higher at a later stage, they are still dogs with even a mature mucocele. If you look here, there's more than 20% of the dogs that won't have necessarily any symptoms reported related to that. So how do these dogs now progress? And that obviously depends a little bit what stage you find them, but the progression rate is very variable. So some dogs could progress quicker, some dogs it will be slower, but invariably most of these dogs will progress. There are a few reports of dogs with underlying hypothyroidism that have been treated medically and their hypothyroidism treated, that where it has resolved. But compared with a high number of hypothyroid dogs, the reports of resolution are pretty minimal. Okay. So the progression can be variable. So if they have no symptoms now, when will they develop symptoms? And again, those symptoms can be attributed to certain things. So if we look at what can happen, now there's several things that can happen. The rupture because of the pressure of this mucus building up and stretching that wall is something that can happen, but only in the mature mucocele because you're running out of space. Makes sense that mucus gradually builds up, fills gradually more and more of that mucocele, and as it keeps building up more and more mucus, you're going to stretch that wall and it might rupture. Okay. Now, there's three other things that could happen and could cause quite an acute deterioration, but these can happen at any of these stages. Okay, so what can we see where it suddenly worsens? We can get either bile duct obstruction if part of this mucus breaks off and ends up in the common bile duct and obstructs it. And we know the common bile duct is not very big anyway to pass things through. We said these dogs are predisposed to have problems with the arterial supply, and they could suddenly get an infarction, wall necrosis, and that will cause massive amounts of inflammation and potentially rupture, or these could get secondary infected. So the difficulty always with deciding who you're going to take to theatre, what we're going to talk about later, is that although these dogs might be well now, it is very hard to predict when they suddenly going to become unwell and then require potentially emergency surgery. So going back to our ultrasound, there's certain warning signs on there that should trigger more concern and pushing these dogs further towards surgery, really, as a more emergency surgery. So as we said, just remember, this can happen at any level of the maturity of your mucocele, except for the rupture. So if you find either effusion surrounding the gallbladder, or like here, a hyperechoic mesentery, which is because of the inflammation surrounding it. If you find a dilated common bile duct and sometimes a plug of mucus in there, abdominal effusion, hyperechoic mesentery in general, and then the more obvious sign that you have to take these dogs to surgery would be gallbladder wall defect or rupture, a free-floating mucocele into the abdomen, and these can be found once they start floating around, definitely when it then builds up fluid anywhere in the abdomen, or extrahepatic bile duct obstruction. But you have to remember as well that ultrasound is a very good way of checking for these things, but it has a relatively low sensitivity depending on who does the ultrasound and what your experiences are. But either way, ultrasound, even in the best hands, can still miss some of the ruptures. Okay. Now, what happens when these mucoceles ruptures? Obviously, you get a level of peritonitis there. And what we know from the studies where dogs have been taken to surgery is about a quarter of the dogs with clinical signs, even just the milder GI signs, but a quarter of them will have rupture when you take them to surgery. Okay, it might be early rupture, but there will be a level there. So how are we going to recognize these dogs besides these warning signs, really? Like we said, there's no real difference in the type of clinical signs they present to it. These clinical signs are very similar. They might be slightly worse, but there's so much overlap that it's very hard to identify the ruptured patients. We know as well that when patients rupture their gallbladder, that their ALP, ALT, lactate, white blood cells are higher, but between the patients, you can't really use a cutoff because there is so much overlap. Okay. And what we know as well is that the bilirubin between the patients that are ruptured or non-ruptured, there is no significant difference there. So when people think, well, if it's got a higher bilirubin, then I need to go, that is not necessarily true. Now, it's a good thing to remember, and I was initially surprised by this, but that dogs with gallbladder rupture because of a mucocele can have any combination of normal or increased bilirubin, both in the blood or in the abdominal fluid. Okay, so where we always thought, well, gallbladder rupture without a mucocele, the bilirubin in your fluid in the abdomen will be more than twice the level what it is in the blood. That is not true for dogs with mucocele. And if you think about it, that kind of makes sense because what has happened when it's ruptured is potentially this bit of mucus will get expelled. But because some of the mucus is still lining this gallbladder, there's very little bile in here. And the bit of bile is often encircled by the mucus if it does get expelled and not necessarily communicating with the fluid. So you could have fluid that has normal bilirubin in it or a low level of bilirubin, while the blood might have normal bilirubin in some of these patients, or it might be elevated if you also have an extrahepatic bile duct obstruction, for example. So do not rule it out just on the basis. Now, what is quite specific in these patients, if you look at the fluid, is that you will have lots of neutrophils in there. And then on cytology, you will have these clumps, bigger or smaller, of this bluish gray material, which is the mucus. Now, if you see this kind of stuff in your abdominal fluid, you take them to surgery. You have a ruptured mucocele, okay? Okay, the second thing we said, obviously, these can rupture, but rupture only happens necessarily if they either just get so big and filled up, so in the mature stages, but what can happen at an earlier stage is gallbladder infarction. So you get infarction of that cystic artery, which then can cause necrosis of the wall and rupture from that point. Now, how are we going to detect these, or how can we potentially detect these if we have an infarction? Now, we said conventional ultrasound. From the rupture, we still miss a proportion. From the infarction, which has not ruptured yet, but probably will do so if that wall becomes necrotic, we will miss some of these dogs, okay? So it isn't great. It's the best we got in a normal setting, but it isn't great. Now, people found that if we do it with contrast ultrasound, you do get 100% sensitivity and specificity there. But I don't know how easy in different countries this is to get hold of. Now, one of the markers that we use on a daily basis in our clinics as well is C-reactive protein. So it was looked at in a study and they compared the C-reactive protein level in the blood between the dogs with the ruptured gallbladders and the dogs with the intact gallbladders. And there was a significant difference. Now, the difference is very much that the ruptured gallbladders all had an increase in CRP. However, a proportion of the intact gallbladders also have an increase of CRP. And again, that is quite to be expected because some of these might have secondary infection, or they could have pancreatitis, or they could have other signs. So this will still elevate the CRP. So the CRP might be helpful in ruling out rupture when it is normal. It's not very good at confirming rupture, but it is helpful. Okay. So who would we like to send to surgery? So we would definitely consider any mature mucocele. Okay, we should consider it. If there's clinical signs that we have attributed to the gallbladder mucocele and any ultrasonographer appearance, but definitely this presence of ultrasonographer warning signs, we should seriously consider sending these dogs to surgery. And if there's presence of abnormalities in the blood that are severe enough to worry about what's going to be happening. The problem very much with surgery is the mortality. Now, this is a surgery that has a fairly high rate of mortality. So there is still a vast difference between the dogs we do that are clinically well, the subclinical dogs, compared with the dogs where it is an emergency situation where there's rupture. But if you even look at the elective surgery, you have to explain to the people, your dog is well for the moment, we're going to take him surgery, but there is 5% chance that your dog won't make it out of the hospital. And people find that hard to deal with, definitely in dogs that are asymptomatic. Okay. But then if you look at the figures, what happens with the mortality, if these are ruptured, your odds ratio massively increases that these patients will die within the first 2 weeks. And the mortality, depending on the studies, but goes up to about 17 to 20%, really. So 1 in 5 will die if it has ruptured, which is a vast number. So it gets a lot worse. So once you've got a mucocele, I think you definitely have to start considering this. What option are we going to go to? Now, what we know is that the short-term survival is the main issue here. So less than 2 weeks after the surgery. And there's lots of complicating factors that can happen in those 2 weeks. So we know that a portion of these dogs are hypercoagulable, and definitely pulmonary problems with thromboembolism are definitely an issue that is well recognized. They can have acute lung injury, they can have aspiration pneumonia if they've got regurgitation. We know a fair proportion of these dogs will have biliary complications with either secondary biliary obstruction or problems with the surgical side, but further bile leaking from that point. There's a smaller proportion of dogs that will have acute kidney injury, pancreatitis, multi-organ systemic diseases, and then the dogs with a low blood pressure, be it either intraoperative or postoperative, have a massively increased risk of that. Okay. So what people have tried to do is, well, which patients are more at risk of mortality within those 14 days? And different studies have shown different things, as you get with retrospective studies. But the more consistent things would be older age dogs. Dogs that are jaundiced are more likely to die and have clinical signs, as we said, are more likely to die than the asymptomatic dogs. Patients that are azotemic, high lactate, high bilirubin, evidence of rupture, although in some studies that has not necessarily shown that it was a risk of mortality. The more advanced stages, and dogs with Cushing's and concurrent pancreatitis. So if we do take these dogs to surgery, what do we want to get out of it? Obviously, we want to remove that gallbladder and suture that up. We then want to submit that gallbladder for histology, because what can we find in the proportion of these dogs? And as you see, between the different studies, there's a huge variation, but there can be a concurrent cholecystitis. And if the bacteria is seen, then you would go and treat it. Now, if you look at the culture of both the bile and the tissues, you'll find about 15 to 20% positivity. But if you have bacteria seen and neutrophilic inflammation into that wall, you would treat it anyway. Okay. We might find necrosis of the wall, and that is definitely a marker that's associated with increased mortality in these dogs. And always, 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 always take a biopsy sample of the liver. And the reason behind that is, yes, your liver values might be elevated because of your mucocele, but that might only be a partial explanation. Once you've done the surgery and these dogs survive and your values don't drop, having to go back in to go and take a liver sample, most owners are not going to be very keen to go for a second surgery there. And some of these things can be very essential, because if you do find a copper hepatopathy in some of these patients and you can treat it because you know it's there, those patients will survive for longer. So it is worth, while you're in there, it will take a surgeon an extra 10 minutes to take a good liver sample and send it off for specific stains there and copper to get you that information. Okay. Now, if we go past the surgery and we look at survival, Okay, there's one paper that very much looks at long-term survival for these dogs. That what are they? What's happening if we treat them surgically, if we treat them medically, or we treat them with both. So if we split these patients up and we look at the surgical survival, we look at the survival of the dogs that's been treated straight away with surgery. These dogs do very well. The median survival time is almost 5 years, which is significantly longer than the dogs that were treated medically with a median survival time over 3.5 years. Now, obviously, take into account the average age of these dogs at presentation is 9 to 10 years. So these dogs that are treated surgically, they live forever, okay, as long as they survive the first 2 weeks. Now, the other bit they're not study looked at, they split up the dogs that were treated with medication to the dogs that were just treated with medication, never had any surgery, or the dogs that were treated with medication initially and then were reverted back to surgery. Now, what we think is happening with these patients is they are dogs that are doing quite well. We decide to treat them medically. They're older dogs, they have very little symptoms. We treat them medically, and then suddenly things go wrong and they decide to take them to surgery. Now, these dogs drop off quite quickly. Okay, the median survival time of these dogs is less than 7 months. So what that means is that we very much say to people, it's fine if you say, I do not want to put my dog through surgery, but you have to be relatively certain about that, because if you're going to change your mind when they become unwell, your chances are going to be much against you, okay? So what I hadn't put, I thought I had put a third slide about this study in there, which basically showed the survival time, or if you go look at all the patients from day 0 when a decision is made for surgery or medication. These stats are only looking at the dogs that survived the first 14 days. Now, when this paper looked at the same patients that went for surgery or medication straight away, a lot of these surgery patients dropped off within the first 2 weeks, and they're not included in these later statistics. So if they looked at the survival time on average from day 0, with all the dogs included, there was no significant difference between medication and surgical survival, okay? So who can we treat medically? What is reasonable? As we said, well, in the ideal world, if there's a mature mucocele, if there's clinical signs, if there's warning signs, you're going to send all these to surgery. But not every owner will want to go for surgery. So it is reasonable to try medical treatment if they have no clinical signs and if it's an early found mucocele, so an early stage, and where the owner declined surgery. Now, what can we do medically for these dogs? Well, what do we do? But what we don't know is how much does it help. So we're going to put these patients on bile thinners, so deoxycholic acid. Okay. We're probably going to put them on some antioxidant because there's going to be some oxidants being released by the liver damage and things there. So we're going to assume that SAMI will help and Sibylline. Some of these dogs we might give antibiotics to if we think there's a bacterial component to it. And we're going to monitor these patients with ultrasound. So initially what I would do is, if the dogs are well, is repeat the ultrasound 1 or 2 months later to have an idea in this patient, how quickly is this disease progressing? Okay. And then you might leave it a little bit longer if it doesn't seem to be progressing quickly, and book a routine recheck maybe 3-4 months later. However, always tell the owners, if your dog develops acute onset gastrointestinal signs, we need to see this patient back. Because as we said, some of these complications, the rupture, the necrosis, that can happen quite suddenly, and they need to be taken serious. Okay. But repeat ultrasound is very little value if the owners have definitely made up their mind they're not going to go for surgery, because it's not going to change what you're going to do. Now, what we want to do with these patients as well, check if there's any concurrent diseases, and diagnose and treat these. Now, if we look at the concurrent diseases, as we said in the start, we're talking Cushing's disease, hypothyroidism. And in the studies, just going quickly into that hypothyroidism, there's definitely studies out there where they checked this dog with a thyroid plan, and they were very clinically hypothyroid on the values they got without showing any concurrent symptoms of hypothyroidism. So don't rule it out just because they don't have any of the other symptoms there. Hyperlipidemia, okay, is definitely a disease that is associated with it. Make sure that when you take the blood samples, have them staffed properly. Proteinuria, we see it very, very commonly in dogs with mucocele, okay, and hypercoagulability. Now, it's a lot harder to diagnose that in practice because obviously TEG is not available. But what we don't know, we know that these diseases or these problems are common in our patients with mucocele. What we don't know is how it influences progression of the mucocele in these diseases, and does it increase the risk for surgery in some of these patients where we haven't controlled the underlying disease? So those are questions we don't have the answer for yet. So to try and summarize it, and what I want you guys to take away from today is it's a disease that we mainly see in older, small, purebred dogs. It consists of the disease happens because immobile complex gallbladder contents that has changed in appearance of normal contents there, and it can cause clinical signs at any stage. If you get warning signs, have a strong recommendation for surgery, because even though they might not be at death's door, something might happen quite soon. Okay. And be aware that there's limitations of the bilirubin measurements. Do not rule it out just because your bilirubin is normal. Okay. These are quite intensive care patients. So I think before you start doing surgery on these in general practice, I think definitely the blood pressure management and everything as the follow-up care, it is an essential part if you're going to send these patients to surgery. Because even in referral settings, we have a 20% mortality rate if these are sick patients. And the bit to remember is check for concurrent conditions and try and treat those. And that for the moment, we have poor evidence for medical treatment and what is improving what and how much does it improve the situation. So I think that is my last slide on gallbladder mucocoele, and I hope I've given you a quick overview on what we know these days. And then I have put just the title for the next talk. I think on the next one, we're going to stay a bit. I mean, this was not an endocrine talk, but we're going to talk a little bit more about Addison's not being just a dog disease. So we'll talk about dogs, but we put a bit more perspective on what's happening in cats, because they're definitely out there, and it's not a common disease, but it's definitely underdiagnosed in our feline population. Okay, and let's go back into the room. Does anybody have any questions for me about the talk? See what's happening in the chat. If you've got any questions, either speak up or put them in the chat, whatever you prefer, really. Do you want to come off mute?
Yeah. Hello there.
Hello. We can hear you.
Yeah, thanks, Louise. Yeah, so my first question is like, preoperatively, I mean, pre-operation, any technique, I don't know, any treatment, anything to do just to kind of increase the cervical ratio just after the surgery, like beyond the treatment, I mean, beyond the medical treatment. Like I heard some about placing a catheter, a drainage catheter. I mean, do you suggest it or not? Like
to the common bile duct?
Yep.
I know some people will do. We very rarely. I mean, it depends a little bit. So the drainage is very much if you have any concern about your common bile duct, as far as I understand it from a surgeon, as I'm obviously not a surgeon, they will place one and they will suture it in place, which they will place retrograde from the papilla into the common bile duct. But I know we definitely don't do it for every patient. So I don't think it's standardly done unless they have any concerns that there's still more sludge there to come out and to keep that patent.
So it's just that the medical treatment before the surgery, like liver protectants, I mean, antioxidants, fluids. It's all that and surgery, yeah?
I wouldn't worry too much about the antioxidants in the patients that you're going to go and take straight for surgery. The antioxidants and the UCDA is mainly for the patients that we're going to treat medically and not go for surgery. On the short term, I mean, because these are very much oral treatments, on the short term, I think they will make a minimal difference. But we know that there are a proportion of these dogs will develop ileus after surgery. So keeping an eye for that, because if they then start regurgitation, it's a risk factor for aspiration pneumonia. We know blood pressure and monitoring it even after surgery on recovery. If these dogs are not straight up, then keep an eye on it because that is a significant risk factor for deterioration. People are looking at the hypercoagulability and should we be treating these before we take them for surgery or not, but there's no clear guidelines as far as I'm aware on that, no clear evidence which one is better, the increased risk of bleeding or the increased risk of clotting. And then the bit that people look at as well is if there's underlying disease like hypothyroidism or Cushing's disease, should we be controlling this if it's an elective surgery before we send these dogs to surgery? But obviously, in an emergency setting, we do not have that option.
I got it. So the other question is like within that critical period, that 2 weeks after surgery, which the mortality rate is high. What are like prognostic biomarkers to check? Like we can check those ultrasound markers. I don't know, liver enzymes, bilirubin, anything. Just to make sure, like my dog is not going to be dead soon.
I think it's probably more dependent on the clinical features because the levels are so different with the alphas and the ALT, and often it takes a while for these levels to drop. So there's no evidence that if they don't drop within 3 days, that's a bad prognostic factor. I think very much looking at the clinical picture and then adjusting to these dogs, because obviously things when we look at pulmonary thromboembolism, before they happen, they're very difficult to say who's at more risk and who's not, unless you have a tech machine. If we look at things like aspiration pneumonia, it is the regurgitation, but that is not a marker we can see on blood. The main thing is very much the blood pressure to monitor. And if these patients don't do well and don't steadily recover, then I would go and repeat the ultrasound and I would go and repeat the lactate and see what we're doing with perfusion wise. But there are no clear markers that we can say after surgery compared with all the rest that we know post-surgery with perfusion and blood pressure and everything there. But for these patients that are more specific that we should be checking. I think that is very much a patient management and regularly rechecking and having brilliant nurses, because I think they will pick these things up and they worry about the patient because they know the patient more, they spend more time with them. Making them feel comfortable to flag up with you that there's something wrong. I mean, they're invaluable because they will pick it up and they often are. The good nurses are often right about their patients when they say they're just not right, and that you go and recheck things then really.
Oh, thank you. You just made it clear for me. And sorry, I took all the time to ask my questions. My last
That's
question.
all right.
Yeah, the
That's
condition, the condition when there is a rupture in gallbladder, it's painful. So, do you suggest to use opioids? I mean, pain management?
Yeah.
Before surgery,
Yeah,
or
yeah. We
just
use a lot of opioids. We use a lot of opioids in this patients. Obviously, it's a multimodal analgesic approach. I mean, for these patients, obviously, we use a lot of opioids. Definitely methadone gets used an awful lot. I know the anesthetists are very keen on top of that to use meropenem because, but at a double dose, so 2 mg per kg injectable has shown to cause a better abdominal pain control than some of the other drugs. We obviously don't use any non-steroidals in these patients. So yeah, absolutely. I think opioids are generally the mainstay of our treatment in these dogs.
Great, thank you.
Support, I mean, nutritional support we need to consider after the surgery, getting these dogs to eat fairly soon after the surgery, as with any of the diseases we know helps with their recovery.
Yeah, right. Thank you.
Thank you. Anybody else? Nope. Okay. Well, if anybody joined us late, drop us a line on LinkedIn or whatever, and we can always send you the recording. I'll write a summary up to put it in our newsletter as well. So if you want to be receiving that one again, drop us a line and then we'll make sure you get included. And maybe I'll see some of you in 2 weeks' time. Thank you all for joining and making this interactive, and have a lovely afternoon. Thank you.